So lately everybody's been joining the NBME streams, and that's been going really well. NBME streams are usually going to be on weekdays from 12 to 3. Today though, right now it's 10 a.m. over here, so I'm just going to continue on the first aid playlist. This is where we left off last time. In the last video we did for neurology, we had looked at your neurodegenerative disorders, made a good understanding of Alzheimer's, Parkinson, Huntington, and then the others that have some overlap, right? So we looked at frontotemporal dementia, which has hyperphosphorylated tau PIC bodies, right? And that same hyperphosphorylated tau PIC bodies are also seen in Alzheimer's. So frontotemporal dementia and Alzheimer's are always going to be both answer choices that are given when you get a question with someone having hyperphosphorylated tau protein. And for Lewy body dementia, this one was pretty straightforward. This was always going to be really easy to find because it's the only neurodegenerative disorder we have where you get visual hallucinations, right? So that's what made this different. However, this had a comparison with Parkinson disease because Parkinson can also cause the dementia stuff, so you have to be careful. And the main difference was this last sentence here. So Lewy body dementia is if the cognitive and motor symptoms occurred very close together, right, less than 1 year apart. Otherwise, if the cognitive and motor symptoms appeared over a year in difference from each other, then that would be dementia secondary to Parkinson's disease. So those two guys have their things to compare. These guys don't really have much to compare with, right? Vascular dementia is literally as its name. It's a lot of blood vessel injury causing dementia in a patient. And then the other one, Creutzfeldt-Jakob, that's the one with the prions. So be ready for that. We looked at a lot of images as well. Now, the next thing on this page is idiopathic intracranial hypertension. So this is also known as pseudotumor cerebri, and I have a question here about it as well from UWorld. You're going to have increased intracranial pressure with no obvious findings on imaging. Risk factors include a female patient who might be taking tetracyclines, might be obese, might have a history of vitamin A abuse, and might be taking danazol, any of these things, right? So you're going to be watching out mainly for an obese female patient and then see if they're doing any one of these things, tetracyclines, vitamin A, or danazol. Findings of that patient would be headache, tinnitus, diplopia, usually from cranial nerve 6 palsy, no change in mental status. Impaired optic nerve axoplasmic flow leads to papilledema. Now, this phrase right here, the impaired optic nerve axoplasmic flow, it's actually a pretty big deal. This UWorld question, that was actually the answer. So if you read this statement and overlooked it and were like, all right, I don't know what the heck that is, but papilledema, okay. Well, you would get this question on UWorld and not really remember what impaired optic nerve axoplasmic flow meant, right? Papilledema was not the answer. Visual field testing shows enlarged blind spot and a peripheral constriction. Lumbar puncture would reveal an increased opening pressure because of the very, very high intracranial pressure. It all gets transmitted down the entire CSF route. And if you do a lumbar puncture, it would provide temporary headache relief. Treatment would be first to lose weight, and then you could take acetazolamide. You could do invasive procedures for refractory cases like a CSF shunt, but it's pretty hard to do, and that comes with many complications, all right? Optic nerve sheath fenestration surgery for visual loss is another option, but that's extremely expensive. So if you look at this question, you have a 31-year-old woman coming to the office due to transient visual changes that are characterized by loss of vision for a minute and are commonly precipitated by bending forward or lifting heavy objects. So there are only a few things really that can cause transient vision loss. You could think of multiple sclerosis. You could think of this, idiopathic intracranial hypertension, and that 1 minute isn't even that big of a deal. So it sounds more like it wasn't exactly blindness, but more so compression of the optic nerve or something like that, where visual information stopped being transmitted for a momentary time, especially in this momentary time of increased pressure. Right? Bending forward increases pressure in the head. Lifting heavy objects always increases pressure above the neck. She has had persistent headaches over the last 3 months that she attributes to migraines. The patient takes over-the-counter analgesics as needed. blood pressure is 140/90, and pulse is 72 per minute and regular. Her BMI is really high, which tells you that she's pretty overweight. Right? This is over 30 is pretty much obese. This is over 31. Fundoscopic exam of both eyes revealed papilledema, which is the giveaway word. With obesity and papilledema, you can start thinking idiopathic intracranial hypertension. What most likely caused the observed fundoscopic findings, right? And then they gave you this kind of fundoscopic finding, right? And this is papilledema. Papilledema is supposed to be like a nipple kind of finding, so this is like the nipple, right? And you're looking at it, and they give you another image in the book itself. So you have the same nipple kind of finding and really, really prominent arteries, right? They're really red and thick. So the answer here, as soon as you look at the answer choices, you would know that it should be impaired optic nerve exoplasmic flow. 50% of students incorrectly selected elevated intraocular pressure. Right? Now, intraocular pressure is a really nice baited answer choice, but that makes no sense. This would literally be pressure inside the eye, and that's not what's happening, right? Even in idiopathic intracranial hypertension, that's intracranial, it's inside the head, it's inside the cranium, right, in the brain, whereas intraocular was pressure inside the eye. So when you read that answer choice, you should be like, wait, it can't really be pressure only inside the eye. That would really not make sense for this patient. But that would give you a fundoscopic image of optic disc cupping due to optic disc atrophy, and it would typically present with painful monocular vision loss, only one eye, headache, vomiting, and conjunctival injection with a poorly reactive mid-dilated pupil. And that's not what we had. When we get to ophthalmology, we're going to see all different kinds of fundoscopic images and see what it's related to. So this patient had this papilledema fundoscopic image. This patient is presenting with pseudotumor cerebri or idiopathic intracranial hypertension, which typically occurs in young obese women with daily headache, bilaterally symmetric papilledema, and transient visual disturbances related to impaired cerebral venous outflow and elevated intracranial pressure, right, but not intraocular. So the activity, right, related to impaired cerebral venous outflow, that was the activity that she was doing. Bending forward and lifting heavy objects, stuff like that, could be related to where she works, maybe. And every time she does those things, she's going to have those visual difficulties. Symptoms worsen during Valsalva as the intracranial pressure increases. This buildup of pressure compresses the optic nerve externally, impairing exoplasmic flow within the optic nerves, causing bilaterally papilledema. Right, so if you compress the optic nerve, all kinds of things happen. We're going to see questions soon enough when we get to ophthalmology where a compression of the outer part of the optic nerve is a really thick nerve, and there's an outer part and a central inner part. The outer part is parasympathetic, and when you compress that, you get the patient having mydriasis, dilated pupils. The central part usually gets damaged in diabetic neuropathy, and if you damage the central part, that part is sympathetic, so you get other issues, and generally speaking, both of them are going to have your eye going down and out, because you're going to lose your actual sympathetic innervation. So down and out, but the mydriasis is a giveaway for the parasympathetic part, and this is good revision for when we see it. So if you have a patient with mydriasis and is down and out, they probably have some kind of aneurysm compressing the outer part of the optic nerve. So that was idiopathic intracranial hypertension. We already looked at this image last time. We were looking at Huntington. We talked about how one of the major pathophysiologies of Huntington was due to a lack of good Huntington protein. So the mutant Huntington protein turns off histone acetyltransferase. So your histone deacetylase works more, right? And deacetylase takes the acetyl out off of it, so you deactivate in a sense, right? We talked about how not to pick methylation as the answer. Yes, methylation mutes the protein. Methylation mutes the transcription and all that, but deacetylation also does. If you take all the acetyl off, that deactivates it, and you get this condensed chromatin now, where you can't do transcription of neurotrophic factors. So you end up getting impaired neuronal survival, and you get nerve damage. All right, so histone deacetylation is the major pathway of why you have brain damage in Huntington, because you lost your histone acetyltransferase. On the next page, they talk about hydrocephalus, which is usually a really good giveaway question. You really should not get this stuff wrong. There's a communicating, non-communicating, and then the ex vacuo ventriculomegaly. So generally speaking, communicating versus non-communicating. We looked at a lot of pathologies in neuro in the beginning, even in the anatomy and physio area, where they would tell you that a certain thing presents with hydrocephalus. You need to make sure you know what kind of hydrocephalus, though. And previously, in like 2018 and 2017, they didn't really used to write what kind of hydrocephalus you would see. But now they've been doing it. They've been writing it in for everything lately. I think, it was in embryology. Yeah, it was right here. So one of the things you get hydrocephalus in is, let me see. Yeah, the Chiari stuff, right? So if you have a Chiari 2 malformation, you're going to get a non-communicating hydrocephalus. Previously, it just used to say hydrocephalus, and then I would have a note here saying it's a non-communicating hydrocephalus, but it's pretty much implied because of the nature of this Chiari 2 malformation. You should understand that it is going to be non-communicating hydrocephalus, but now they explicitly put it there in case it's not implied for someone who is still studying. So make sure you understand what the difference is. In a communicating hydrocephalus, all your CSF is communicating just fine, which means that all the CSF flow routes are fine, but the CSF is not absorbed in the end by the granulations. In a non-communicating hydrocephalus, this is also an obstructive hydrocephalus, which means that something is impeding CSF flow, causing a buildup before the point of blockade. Right? We looked at the flow of CSF last time, and we looked at different kinds of pathologies regarding that. So we'll see that again as we go on to, let me see. Yeah, that's going to come up later on. So we'll see that when we go on later on. But just make sure you understand what that means. So if you have CSF not flowing correctly, then you're going to be looking for a non-communicating hydrocephalus. This is always caused by a structural blockage of CSF circulation within the ventricular system. It could be the stenosis of the aqueduct of Sylvius, or a colloid cyst blocking foramen of Monroe, a tumor blocking one of the other foramens. It could be anything. Communicating hydrocephalus can be communicating or normal pressure. In communicating hydrocephalus, the general version of it, the general communicating hydrocephalus has decreased CSF absorption by the arachnoid granulations. Right, so that's what we were saying. All CSF flow routes are fine, but in the end, it's not being absorbed. This can occur because of arachnoid scarring post-meningitis. It can also occur because of trauma, where you might have damaged the granulation area. So with the decreased CSF absorption, you end up having increased intracranial pressure, papilledema, and herniation of the brain into different parts, which can squeeze your optic nerve and squeeze your cranial nerve 3 and all kinds of stuff. We're going to see brain herniation as we go on too. So those are two things you want to make sure when you look at, you revisit this section. So very similar to the idiopathic intracranial hypertension, you're going to get a patient coming in with increased intracranial pressure, papilledema, and possible visual disturbances. Most likely, though, for step 1, this communicating hydrocephalus patient will not be female. There also won't be a patient who's going to be obese. Those two things won't be there. Right, so this communicating hydrocephalus patient will probably be a male, and if it is a female, she won't be obese. So at that point, you're going to start looking at, like maybe in the history she has post-meningitis, maybe in her history she has some kind of brain trauma, anything like that. The other communicating hydrocephalus is a normal pressure hydrocephalus. This affects the elderly. Right, so it's going to be idiopathic. It just happens for no explainable reason. The CSF pressure is elevated only episodically. Does not result in increased subarachnoid space volume. Expansion of the ventricles distorts the fibers of the corona radiata. And these fibers of the corona radiata are really significant when it comes to urinary incontinence. Urinary incontinence is a really big, high-yield topic for step 1. In normal pressure hydrocephalus, you get a patient with a triad of urinary incontinence, gait apraxia, or a magnetic gait, where basically they walk, it's almost like a shuffling gait, they walk with their feet kind of stuck to the floor, and cognitive dysfunction, so wet, wobbly, and wacky, symptoms potentially reversible with the CSF shunt placement. Right? So the distortions would get fixed up and the ventricle expansion would be reversed. Ex vacuo ventriculomegaly is this last one over here. This one basically is an appearance of elevated CSF on imaging, but it's not. This is actually relatively increased CSF. The real issue is decreased brain tissue and neuronal atrophy. So ex vacuo ventriculomegaly can be seen in Alzheimer's disease, advanced HIV, Pitt disease, and Huntington disease. The intracranial pressure is normal, and the normal pressure hydrocephalus triad is not going to be seen. So this patient, with the really big ventricles here, it does look like this patient might have hydrocephalus, but it's not. It's actually brain atrophy, which you could tell by the rest of the brain really not being there. It's gone. The rest of the brain is being destroyed. In A, what you're seeing is really, really big ventricles here, right? So that's your expansion of the ventricles in normal pressure hydrocephalus. Right? Whereas here in B, this is clearly some kind of tumor, right? So this is going to be a non-communicating hydrocephalus where you're causing a blockade of CSF flow. Generally speaking, if you don't get a tumor, then you're going to get a similar image like this, and it can still be non-communicating hydrocephalus, so it's not a giveaway. Make sure you understand that. A question can give you an image like A, but the answer might be non-communicating hydrocephalus, and this image of A is basically showing you dilated ventricles because there's some kind of blockade after the ventricles, right? You get dilation before the point of blockade. So the images are not exactly a giveaway. I mean, this image is definitely a giveaway, but this image can be for both things, right? This image is a giveaway that there's a tumor and it's a non-communicating hydrocephalus, but A could also be a non-communicating hydrocephalus. So now we have two different questions here from UWorld. First one, 43-year-old man with a history of HIV who is non-compliant with his highly active antiretroviral medications comes to the office due to progressive memory loss and cognitive decline over the last several years. So he has HIV and doesn't take his medications. He has problems with attention, concentration, and speech. In the past few months, he has been more apathetic and increasingly lethargic. More recently, he has hard difficulty with balance and has fallen on multiple occasions. The patient has had no headache, tremor, changes in vision, fever, nausea, vomiting, or urinary incontinence. Non-contrast head CT scan reveals diffuse cortical atrophy with some enlargement of the ventricles. A CT scan is given, and it's exactly as the last sentence described. What caused this condition? Well, if you have a patient coming in, and anytime you get a CT scan of a hydrocephalus thing, so the CT scan showed you, what was it? Diffuse cortical atrophy. So it's going to look like image C basically, right? Cortical atrophy and enlargement of the ventricles. You already know that it's not that this patient has actual hydrocephalus. There's no lack of absorption that you would have in communicating hydrocephalus, nor is there a blockade like you would have in non-communicating hydrocephalus. This is just hydrocephalus ex vacuo. You would see that in your answer choice, you would just pick it. Patients with neurodegenerative diseases like AIDS, dementia, and this patient can develop ex vacuo due to significant cortical atrophy, allowing ventricles to expand while maintaining normal CSF pressure. So you don't see that triad of wet, wobbly, and wacky. This one here, 64-year-old woman with a history of close traumatic brain injury, is evaluated in the clinic due to progressive gait disturbance over the last 2 years. So 64, so she is really elderly. The patient has had difficulty concentrating, forgetfulness, and lack of interest in daily activities for the past year. She has also developed new-onset urinary urge incontinence, and as soon as you see that, you start thinking normal pressure hydrocephalus, with several episodes over the last 6 weeks. So she just keeps peeing, urinary urge incontinence. The patient has no tremor, visual changes, headaches, or nausea, vomiting. Her mini mental state exam score is 20 out of 30, with exceptionally poor performance on executive function tasks. On physical exam, she has increased tone and hyperreflexia of the lower extremities, along with a slow gait and decreased step height. So what they're describing here is a magnetic gait. A decreased step height means that when you're taking steps, you don't tend to lift your feet up as much as you should be, right? So you're kind of shuffling your feet on the floor. Her head CT scan is shown below, and it looks like the image A above, so this one. Except the white is all black. So that's basically, remember we talked about this? Let me I'll go back to that. But this white stuff, instead of showing it bright white, they're showing it all black because they're using a different contrast, right? That's the difference between T1 weighted versus T2 weighted. And we talked about that right in the beginning. Right in the beginning, when you look at these three, right? If you have T1 weighted, the CSF is dark. Whereas if it's T2 weighted, right, the CSF is bright. So what do you see that's white in T1? Well, T1, the white matter will be all light colored, and any fat would be bright, but there's no real fat in the brain per se. So when you do the T2 weighted, you really focus on CSF, right? But if you do the T1 weighted, you're really focusing on the rest of the brain and the white matter instead. So for some reason, you know, and this image that's given here, this one has white CSF. This is T2 weighted. You're focusing on the CSF. In T1 weighted, the brain is number one, so you would be focusing on the brain, which is what you're seeing in images B and C. B and C are T1 weighted. Alright, so that's why you're focusing more on the brain, here on the tumor, here on the actual atrophy of the brain. But in this one, this is T2 weighted. You're focusing on the fact that there's a lot of CSF. Either way, when you see this patient, you understand that she's really elderly and she has the wet, wobbly, wacky stuff going on. This must be normal pressure hydrocephalus. She has decreased CSF resorption due to her brain trauma that may have scarred her arachnoid granulations. When periventricular white matter tracts are disrupted due to the expanding of the ventricles, symptoms progressively appear, just like we saw. Right? So she understandably has a communicating hydrocephalus, but a normal pressure one, not the increased pressure one. So hydrocephalus questions are almost always going to be really straightforward, really shouldn't be much to be confused by, and you should get it right. And oftentimes you won't even need the CT scan. Okay, so this next big topic is actually really high yield, very, very significant, and a really important topic to make sure you grasp very well. Questions on multiple sclerosis can actually have any sentence that you're seeing on this page as an answer choice. So I'm going to show you everything I can tell you about multiple sclerosis, and then we'll do these practice questions down here. So multiple sclerosis, autoimmune inflammation and demyelination of the CNS, which includes your brain and spinal cords, with subsequent axonal damage, can present with these four things. Acute optic neuritis, which is painful unilateral visual loss associated with the Marcus gun pupil. Brainstem cerebellar syndromes like diplopia, ataxia, a scanning speech, an intention tremor, nystagmus, and INO, intranuclear ophthalmology. We're going to see that when we get to that. Pyramidal tract demyelination, which leads to weakness and spasticity, right? We looked at the different tracts and we know what the pyramids were for. So that was related more to the corticospinal tract stuff. Spinal cord syndromes like an electric shock-like sensation along the cervical spine on neck flexion, also known as the Lermite phenomenon. So this can be a patient, right? You can get a patient that literally comes in and says, I went to get a haircut yesterday, and my doctor asked me to my barber asked me to flex my neck or something, and I had this weird shock-like sensation. So that's one way this can present. Another scenario would be like some guy might be working out and he flexed his neck and he got this weird electric shock-like sensation along the cervical spine. So any presentation like that should be really concerning for multiple sclerosis, as well as a neurogenic bladder, paraparesis, sensory manifestations affecting the trunk or one or more extremity. Symptoms may exacerbate with increased body temperature, like a hot bath or exercise. Relapsing and remitting is the most common clinical course. Most often affects women that are really young, in their 20s and 30s. More common in individuals living farther from the equator, which is not really something people can explain. So that just happens. What are you going to find? So finding is going to be elevated IgG level and myelin basic protein, MBP, in the CSF. You're going to note something called oligoclonal bands, which are diagnostic. So what are oligoclonal bands? Looking at this, right, you're looking at a normal one and a multiple sclerosis patient here. You're looking at all the different protein bands, right? All the different protein bands. And in the normal one, IgG has a uniform band. Right? Very uniform. No one place is really dark. Like there's that dark part up there, but the rest of it is pretty uniform and a nice transition of gray. And then all the other protein bands are down here. If you look at a multiple sclerosis patient, their IgG has multiple dark lines. You could distinctly pick out a couple of dark lines. Those are oligoclonal bands. When you see that in a multiple sclerosis patient, you can pretty much diagnose them with multiple sclerosis. MRI is the gold standard. On MRI, you would basically see periventricular plaques like this. Right, so next to the ventricles, you have these white areas of plaques. These are areas of oligodendrocyte loss and reactive gliosis. Right, so you're losing oligodendrocytes. Multiple white matter lesions that are going to be disseminated in space and time. So what that means is you're going to have lesions that are not all occurring at the same time, and they're all occurring in different parts of the brain. Right, not in just one area of the brain. So on the top I wrote, in multiple sclerosis, the initial insult starts with Th1 helper cells which react to myelin basic protein, causing them to secrete interferon gamma, activating macrophages to destroy myelin. So that's the immunology. Right? You need to know the immunology too, because you can get a question on multiple sclerosis, but the question might actually be about the immunological way multiple sclerosis occurs. This would be a type 4 hypersensitivity reaction because it's just a Th1 helper cell reacting to something as if it's like something you're allergic to. Bilateral internuclear ophthalmoplegia is practically pathognomonic for multiple sclerosis. In the MRI below, this one, you can see plaques in the cerebral hemisphere as well as in the ventricles. Symptoms come and go, and the patient can present multiple times to your clinic because their symptoms are getting worse. Right, so you can see even in this MRI, the lesions are disseminated in space and time. They're all over the place. And the time aspect would really only be clear if in a question they tell you, like 6 months ago, CT didn't have that or MRI didn't have that. Right, that lesion wasn't there 6 months ago. Activated CD8 positive T cells, remember because Th1, right, so CD8. CD8 positive T cells release cytotoxic granules that injure oligodendrocytes, leading to oligodendrocyte depletion with relative sparing of axons. Oligoclonal bands represent the intrathecal production of immunoglobulins and are highly sensitive for multiple sclerosis but non-specific. Marcus gun pupils, so ARAPD, Marcus gun pupils where the patient pupil constricts less, therefore appearing to dilate, when a bright light is swung from the unaffected eye to the affected eye. And we're going to see this later on when we get to the ophthalmologic stuff. The RAPD stuff will also make sense when we get there too. But Marcus gun pupils, so you're going to see this kind of explanation, right? They're going to tell you that the pupil constricts less when a bright light is swung from the unaffected eye to the affected eye. When you have a bright light on your eye, your pupil should constrict. A Marcus gun pupil will not constrict. That's basically the concept there. And the reason it's not constricting is because it's not really recognizing the light. It's not seeing the light. Some kind of blindness, okay? Internuclear ophthalmoplegia is also one of the last topics, I think, in ophthalmology. So this is a lesion of your medial longitudinal fasciculus, causing one eye to have trouble adducting. Right? So if you're looking towards the left, your right eye will adduct. Right? Adducting means looking towards your nose. So if you're looking to the left, your right eye has to adduct. And if you're looking to the right, then your left eye has to adduct. In internuclear ophthalmoplegia, you're unable to adduct one eye when you look towards a certain direction. However, convergence is normal. So if you're making both eyes look to the center, that works fine. Right? So the medial longitudinal fasciculus is something that's responsible for helping both eyes communicate with each other. So you can make sure both eyes are looking in the same direction at all times. If you have injury to it, you won't really be able to do that very well. So that being said, that's everything you need to know about multiple sclerosis. Mainly the only things I added here was the immunology part of it. Right? You need to know the immunology as well. Type 4 hypersensitivity, Th1 helper cells against myelin basic protein, C8 positive T cells attacking oligodendrocytes. So now, how do you fix this? Treatment, you have to stop the relapses and halt or slow the progression with DMTs, disease-modifying therapies. We talked about disease-modifying therapy before too, way well, it wasn't too long ago, right here, we were looking at rheumatoid arthritis, right? Rheumatoid arthritis had these DMARDs, right? Disease modifying anti-rheumatic drugs. So that's also a DMT, but specific to rheumatoid. Here we're seeing DMT specific to multiple sclerosis. So disease-modifying drugs, disease-modifying therapies. You could give beta interferon, glatiramer, natalizumab. Any of these are going to be things that are really just disease-modifying therapies. There's no real cure to this. You can treat acute flares with IV steroids. Symptomatic treatment for neurogenic bladder is going to be any kind of muscarinic antagonist like bethanechol. Right? Bethanechol, remember when we were in pharmacology, always good to revisit that stuff. So if you see medications you don't know, you should Google it. Like I'm sure a lot of you probably don't know what glatiramer is, so you should Google that too. We'll do that. But let me just show you what I was talking about here. So symptomatic treatment for neurogenic bladder. So if you go to your pharmacology section, where they talk about cholinomimetic agents, right? So bethanechol, carbachol, methacholine, and pilocarpine. These are all muscarinic agonists, right? They all work with your M receptors, mainly M3, and they help you with different things, and they basically mimic acetylcholine. That means that they mimic parasympathetic things, right? Parasympathetic things. So rest and digest related stuff. And that's what they're saying here. So you could give a muscarinic antagonist, right? Because you're not trying to pee. These people have a neurogenic bladder. You need to make them not pee. So if you go back again, the latter half of that page, was the antagonist against acetylcholine. Mainly things that kill acetylcholine, right? So you're gonna have no, these are also agonists. Let me see. Yeah, there you go. Muscarinic antagonists. And these are all the main medications you can use to stop acetylcholine activity, right? Against parasympathetic stuff. But they're not sympathetic. These are not sympathetic medications. These are just anti-parasympathetic. And oxybutynin, solifenacin, tolterodine, these are the ones that help with an overactive bladder. Urge urinary incontinence. So these are the medications you'd be thinking of for that aspect. For the mydriasis and cycloplegia, right? These medications actually cause mydriasis and cycloplegia, so you want to make sure you don't pick that if you're trying to fix it. And when you do practice questions, you start seeing more of it. You start seeing more of things that get tested. So any muscarinic antagonist, though, any muscarinic antagonist for the neurogenic bladder, especially those three that I just showed you right there. Muscle spasticity is a pretty high yield question. UWorld still asks about it. Anytime you see muscle spasticity, you want to think of baclofen. This is almost always an answer choice there. It's just a GABA agonist, and GABA is inhibitory, so it stops the spasms from happening. That's it. And then for pain, you could use TCAs and anticonvulsants. But all in all, there is no actual cure for multiple sclerosis. Alright, so let's take a look at these UWorld questions down here. A lot of them just are repetition of the same stuff. So it really gets to show you like what you need to be paying attention to. And also pay attention to the presentation that the patient is coming in with. So first one, 32-year-old woman comes due to left eye pain accentuated by ocular movement. She has periodic dimming of vision in the same eye. She has had several such episodes over the last month, most often after a hot shower or intense workout. So by this point, it's really clear this is multiple sclerosis. A year ago, she had an episode of numbness and tingling in her left arm that resolved spontaneously. Ophthalmologic exam shows swelling of the optic disc. Neurologic exam shows a mild intention tremor and broad-based gait. All of this, which is extra information that can really throw you off. Right? We've already made our diagnosis. After the first two sentences, we already made our diagnosis. She has multiple sclerosis. So any of this extra information might be there for the extra answer choices they have. Neurologic exam shows intense tremor, broad-based gait. What is the most likely cause of her current condition? And the correct answer was demyelinating plaques, right? You're losing your oligodendrocyte. Other correct answers for the same type of question were reduced saltatory conduction because you lost your myelin, you lost your oligodendrocytes, and oligodendrocyte depletion because that's actually what happens in multiple sclerosis. So there were many questions on multiple sclerosis in UWorld, right? And they were all very similar to this, and these were two more answer choices that were the correct answer choice. Right? So demyelinating plaques, reduced solitary conduction, oligodendrocyte depletion, those are the main pathophysiology of what's happening in multiple sclerosis. What's another way you could test someone? So here's this one. 23-year-old woman is referred to a neurologist of recent onset diplopia and ataxia. A year ago, she experienced numbness and paresthesia involving her left leg that have since resolved. MRI of the brain reveals several areas of T2 hyperintensity consistent with axonal demyelination. A diagnosis of MS is made. What neuronal property is most likely to decrease as a result of demyelination? So you didn't even need the whole thing. You didn't need any of this. They could have just asked you what neuronal property is going to decrease as a result of demyelination. Well, the answer choices were related to the myelin stuff. So length constant, spatial summation, temporal summation, time constant, all of these things that when you see it, you could get really, really intimidated. But don't. We've already actually talked about this earlier. And I made it really easy because all you have to do is remember your physics equation. So the physics equation, velocity equals distance over time, right? Velocity is distance over time, miles per second, meters per second, right? Miles per hour. So distance over time. So if you want to have high velocity, right? High velocity equates to a high distance over a short period of time, right? So if you have a big, if you have a really, let me see what neural property is going to decrease it. Yeah. So when you look at this equation, velocity equals distance over time, right? As you make your speed higher, you have to remember that velocity is directly related to the distance and indirectly related to the time. So when they ask you what property is going to decrease because her velocity is decreasing, you know that the distance is going to decrease, right? So the length constant. Or the time is going to increase. The time constant would be the one that would increase, right? Because for this patient, they already told you she has demyelination, she has multiple sclerosis, so that means her velocity is lower than usual, right? So velocity equals length over time, and velocity has decreased in multiple sclerosis, so that means your length or space constant, they're the same thing, is decreased. If time decreased, velocity would be faster because it's taking you a lesser amount of time to get to a certain distance. The length constant is a measure of how far along an axon an electrical impulse can actually propagate without requiring active regeneration by ion channels. Myelin increases the length constant by reducing charge dissipation and increasing membrane resistance. Alright, the time constant would be something that's opposite to this velocity because they're indirectly related. It's in the denominator. So this stuff about length, space, and time constant should never be something that you get confused about, and don't get that question wrong. It's just velocity equals distance over time. And you're talking about how quickly someone is traveling along a nerve path. That's it. So that was one way they asked. This is another question where the answer was oligodendrocyte depletion again. Right? So they had two questions over time where oligodendrocyte depletion was the correct answer for multiple sclerosis. Really straightforward. 34-year-old woman comes to the office due to diplopia, clumsiness of the left hand, and numbness of the right foot. So again, you could tell that her lesions are disseminated in space. You can't see the time part, but they are disseminated in space. Different parts of the brain. 6 months ago, she had numbness of the right hand, which self-resolved. So now you can also say her lesions are disseminated in time, because now she doesn't have the right hand stuff. Her right hand is okay. CSF analysis shows mononuclear cell pleocytosis and oligoclonal banding. Oligoclonal banding, which is this stuff, is diagnostic of MS. What is the most likely to be present in her brain? A lack of oligodendrocytes. That's it. Alright, so they gave you a scenario where her lesions are disseminated in space and time. They gave you the diagnostic oligoclonal banding. And if you could add that all together and understand this is multiple sclerosis, you're done with the question. And the last one, a 34-year-old woman comes to the office due to 2-day history of reduced sensation in her legs. Lately, she has had significant fatigue, especially with exercise. 6 months ago, she had an episode of visual blurring that self-resolved after a few days. Medical history is significant for psoriasis, for which she uses topical glucocorticoid ointment. So now, this medical history sentence was a complete waste of time. Physical exam indicates decreased pain and light touch perception in both legs below the level of the umbilicus. What pathologic brain lesion is most specific for her disease process? So they did a pretty nice job to not give away the fact that this is multiple sclerosis. But you know it is. She has reduced sensation in her legs over the last 2 days. So this is very acute. She has had significant fatigue, especially with exercise, so she can't really work out well. 6 months ago, she had a different thing. Episode of visual blurring that self-resolved after a few days. That part was the most specific to multiple sclerosis. Her having another autoimmune disease just tells you that she's prone to other autoimmune diseases. Physical exam indicates decreased pain and light touch perception, again, which is the stuff that's been happening to her in the past 2 days. All of this in general is telling you she most likely has multiple sclerosis. You look at your other answer choices now, none of them should really be specific to what she has. The other answer choices, I can't put them here, but the other answer choices would really be like related to maybe hydrocephalus or Alzheimer's, stuff like that, and you would be able to knock out those answer choices because you want to find things. When you look at those answer choices, you want to find things that define those answer choices, and you wouldn't find that in her, right? But you do have that visual blurring that's self-resolved. That's the relapsing remitting stuff that kind of defines multiple sclerosis. So what's going to be specific to her disease process? Perivenular inflammatory cells. Now, this answer choice I had to put here because this was different, right? Perivenular. So perivenular inflammatory cells was a very unique new thing that you will put as an answer choice. She has MS, and her excessive fatigue with exercise is known as Uthoff's phenomenon. So we saw the Lermite phenomenon thing. The Lermite phenomenon, where you get the shock-like sensation along the cervical spine on neck flexion. And neck flexion is really a very common thing, right? So when you do neck flexion, especially when you go to the barber, a neck flexion would have that sensation in these patients. The Uthoff phenomenon is multiple sclerosis patients who have fatigue with exercise. So this question was probably the most unique one for the whole concept of multiple sclerosis. And multiple sclerosis is very high yield, so you want to make sure you know that. Don't confuse it with Alzheimer's. Do not confuse it with Huntington, Parkinson, any of that. Note also that in all of these questions, the patients are pretty young. The youngest being this 23-year-old woman, right? Because it occurs between 20 to 30. That's when symptoms usually start showing up in these patients. So be careful of that too. So if you have a patient who's 76, 13, right? These ages would probably not be multiple sclerosis. So I'll stop here for now. In the next video, we'll look at the rest of your other demyelinating and dysmyelinating disorders. And there's a bunch of them here. Not exactly the most high yield stuff, but they're good to know and they're not that hard to know. Probably the most high yield being osmotic demyelination syndrome. So thanks a lot for joining, and then we'll continue this on later on.